Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 533 of our pharmacotherapy series, which majors in anxiety disorders. This case applies to patient BIG in part 532 of this pharmacotherapy series. Several days after recovery from clonazepam intoxication, BIG expresses a desire to discontinue benzodiazepine use. He is being criticized by his fellow Alcoholics Anonymous program members for taking a drug associated with dependency. The decision is made to switch BIG from clonazepam to buspirone. How does the clinical profile of buspirone compare with benzodiazepines? Buspirone lacks CNS depressant effects, sedation, cognitive or psychomotor impairment, respiratory depression, and muscle relaxant or anticonvulsant effects. This makes buspirone useful in older patients who may have a variety of chronic medical conditions. Buspirone is generally well tolerated, and possible side effects include mild nausea, dizziness, headache, and initial nervousness. Unlike many antidepressants, buspirone does not adversely affect sexual functioning and has actually improved sexual functioning in some patients with generalized anxiety disorder. Buspirone has minimal potential for abuse and is not classified as a controlled substance. It does not produce physical dependence or withdrawal syndromes on discontinuation, even after long-term therapy. It also does not interact with alcohol or other CNS depressants and is relatively safe in overdose. Buspirone is a 5-HT1A receptor antagonist and is as effective as benzodiazepines such as alprazolam, oxazepam, lorazepam, diazepam, and clorazepate in the treatment of generalized anxiety disorder. Like antidepressants, buspirone is more effective than benzodiazepines in treating the cognitive symptoms of anxiety. However, the anxiolytic effects of buspirone have a more gradual onset than benzodiazepines. Initial effects are observed within the first 7 to 10 days, but 3 to 4 weeks may be needed for optimal results. Buspirone must be taken on an ongoing basis if it is effective, and the drug should not be taken as needed. The next question reads, how should BIG be switched from benzodiazepine to buspirone therapy? Because buspirone has no CNS depressant effects and is not cross-tolerant with the benzodiazepines, it is not effective in preventing or treating benzodiazepine withdrawal. Thus, when patients are converted from benzodiazepine to buspirone therapy, the benzodiazepine must be discontinued gradually. Because it takes several weeks for full therapeutic effects of buspirone to occur, it can be initiated before the benzodiazepine taper begins. This may indirectly ease benzodiazepine withdrawal by providing extra anxiolytic coverage during the benzodiazepine taper period. Administration with food may significantly increase bioavailability by decreasing the first-pass effect. Some of the side effects of buspirone, such as nervousness, are attributed to its active metabolite, 1-pyrimidinol piperazine, abbreviated as 1-pp. The mean elimination half-life of buspirone is short, approximately 2 to 3 hours, but 1-pyrimidinol piperazine is longer acting. The clearance of buspirone is significantly reduced in patients with kidney or liver disease, but there is little change in side effects or tolerability. Nevertheless, it is recommended that buspirone dosages be lowered in patients with compromised renal or hepatic function and that use of the drug be avoided in cases of severe impairment. Buspirone is metabolized by CYP3A4, and co-administration of CYP3A4 inhibitors, including grapefruit juice, can result in significant increases in buspirone levels. Because of buspirone's extremely wide margin of safety and tolerability, even very large increases in its plasma levels may be clinically insignificant. Buspirone should be avoided in patients taking monoamine oxidase inhibitors and used cautiously in combination with high-dose antidepressants because of the risk of serotonin syndrome. Some studies suggest patients previously treated with benzodiazepines will not respond favorably to buspirone. However, buspirone may provide benefit in this population as long as the benzodiazepine is tapered slowly enough to prevent withdrawal effects. BIG has been taking diazepam for several months and the drug needs to be withdrawn gradually during a period of at least several weeks. BIG can be started on buspirone at this time. The usual recommended starting dosage of buspirone is 15 mg per day given in 2 to 3 divided doses, but a lower dosage, that is 10 mg per day, is indicated in BIG because of his liver disease. Twice-daily dosing is preferred to facilitate compliance and is comparable in efficacy and tolerability to 3 times daily dosing. The daily dosage may be increased in 5 mg per day increments every 3 to 4 days. Optimal anxiolytic doses generally range from 20 to 30 mg per day, with 60 mg per day being the recommended maximum. There are no specific guidelines for adjusting dosages in patients with liver impairment. Therefore, dosage titrations in BIG should be made slowly, according to his response and side effects. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 534.